Thank you for joining us as we introduce our AGA clinical practice update on incorporating FLIP into clinical esophageal practice. I am Amit Patel, Professor of Medicine at Duke University, and I am joined by Dr. Prakash Gyawali, Professor of Medicine at Washington University. Dr. Gyawali, for those clinicians who may not be familiar with FLIP, what is it and how is it performed?
Well, FLIP uses impedance-based technology to measure cross-sectional area within a hollow viscus like the esophagus. The equipment consists of a distensible bag that houses a catheter with impedance sensors. Immediately after a high-quality upper endoscopy, the FLIP catheter is positioned in the esophagus, straddling the esophagogastric junction, and measurements are obtained after distending the bag with electrolyte-containing fluid. Dr. Patel, what can we learn from FLIP?
Well, two metrics are critical to FLIP interpretation, the distensibility index and the maximal diameter at the esophagogastric junction, or EGJ. Using these two metrics, EGJ opening can be categorized as normal, reduced, or inconclusive. The change in diameter can also be plotted against time to identify secondary peristalsis patterns. Dr. Gyawali, what are some of the clinical settings where FLIP may be useful?
Well, FLIP is most useful in diagnosing or ruling out esophageal obstruction, especially when other tests like manometry and barium are inconclusive, or when patients first present for EGD for obstructive symptoms when technology and expertise are available. Intraoperative FLIP can determine adequacy of achalasia treatment, and FLIP can define the mechanism for continuing symptoms after achalasia treatment. Dr. Patel, any clinical pearls for interpreting FLIP?
Sure, as we highlight in the CPU, FLIP should always be interpreted in the clinical context. EGD findings and other test results need to be factored in. For instance, normal EGJ opening with the normal esophageal body contractile pattern essentially rules out a mechanical or motor disorder of the esophagus. Dr. Gyawali, does FLIP have any value in EOE or GERD?
Well, FLIP can provide an explanation for persisting dysphagia in treated EOE, including identification and categorization of strictures. FLIP can also be useful in post-fundoplication dysphagia, but FLIP should not be used to diagnose GERD or to plan anti-reflux surgery, other than ruling out achalasia. Dr. Patel, any final thoughts?
To read more practical advice, as well as see our clinical algorithm on when to order and how to interpret FLIP for your patients, please check out our FLIP CPU and gastroenterology or on the AGA website. Thank you.